Welcome, everyone. We're going to wait a couple of minutes for people that are leaving the plenary session and joining here this afternoon. So welcome. Give us a couple of minutes to as we wait for a couple more participants to join as they log out from the primary session. Thank you. Okay, welcome everyone. Good afternoon. Wow, that was a fantastic plenary session. My name is Dr. Margarita Fontana, and I'm going to welcome you to this session on Carey's risk. Just a couple of housekeeping rules before we begin. This session is being recorded, and you will be provided a link to the recording and the slides at some point after this meeting, as well as the link to those in the other sessions in case you want to look at those other presentations as well. We ask you to please post any questions that you have for this presentations in this session in the chat feature of Zoom throughout the session. You are in the session that is going to be discussing Carey's risk. My name is Dr. Margarita Fontana. I'm a professor at the Department of Cardiology, Restorative Sciences, and Endodontics at the University of Michigan School of Dentistry, and I want to welcome all of you. The other speaker that is going to be sharing the platform with me today is a dear colleague and friend, Dr. Alonso Carrasco Labra. He is director of the Department of Evidence Synthesis and Translation Research at the American Dental Association. Alonso and our presentations are really connected and interrelated. So instead of taking questions at the end of each presentation is about 15 minutes. What we have chosen to do is take questions at the end so we can have really a rich discussion, because as I said, both presentations are interrelated. So before we start, the title of my presentation is looking at Carey's risk prediction models in the area of precision health and the possibilities of a learning health system as we look at implementation of these efforts. I do want to take an opportunity at the beginning to acknowledge and thank the funding that we received in this area from the National Institutes of Dental and Craniofacial Research, NIH, and IDCR here in the United States. And of course, the many collaborators and colleagues that participate either directly or indirectly in the work that or the ideas that I'm going to be sharing with you today. And those are our colleagues at the University of Iowa, Duke University, Indiana University, and of course, many other colleagues around the world, including Dr. Heiko Spalik from the University of Sydney and many others. So this is really the result of collective work. So I want to start just by giving you a little bit of background about dental caries in case you are not familiar with this disease process in great detail, so that we can then go and discuss some of the issues around risk-based care. So as you might have heard if you were part of the plenary session at the wrap-up that Dean Macaulay provided, dental caries is one of the most prevalent oral diseases, and in fact, it's one of the most prevalent non-communicable diseases worldwide. And this disease process results in cavities or holes in teeth, and cavities are the single most prevalent condition globally, affecting more than 2.3 billion people. Unfortunately, this disease process can affect people throughout their lifetime and can have multiple effects on pain, infection, with lasting effects on function, growth and development, and quality of life, and numerous hours lost of schools, hours being missed, work hours being missed, etc. Around the world, unfortunately, there's tremendous inequities and inequalities, not only in the prevalence and severity of this disease process, but in access to care. And because of limited human and financial resources and the skewed distribution of this disease process in many population groups, there has been a call for targeted or precision or personalized care as it relates to caries prevention and management. From an economical perspective, this disease process also has a huge impact on economic burdens globally, with treatment of dental caries or cavities accounting for over $245 billion back in 2015. The good news is that this is a preventable disease, and we know how to prevent it. But it is a wicked problem, and it has been a very wicked and complicated problem to solve, which is why we're still where we are globally. Now, I've added some images at the bottom of this slide to represent different stages of this disease process. These images happen to be in primary or baby teeth. And the good news is that we do have effective preventive strategies that we know work to manage this disease process at different stages of severity. And we also have effective therapeutic strategies. It just happens to be that a lot of the therapeutics are tremendously expensive and many times require access to dental care facilities. And this is a problem for many population groups around the world. So let's move a little bit into the areas of dentistry. In modern caries management and dental care, caries risk assessment is considered one of the initial steps in the cycle of effective and personalized care, with the goal being that we can identify these risk factors early on and intervene so that we can prevent the more advanced consequences of this and costly consequences of this disease process from developing. Now, cavities and dental caries have a huge impact on oral health, and oral health has a huge impact on general wellness and well-being. And general health and well-being. And in fact, many of the risk factors for dental caries are common risk factors for many other health conditions, such as obesity, diabetes, etc. So if you really think about it from that perspective, controlling and addressing some of these common risk factors will not only support oral health and cavities, but also support overall wellness and general health. And this has obviously huge impacts on society, policies, and health determinants. Now, the importance of oral health and the need to improve oral health is exemplified in the resolution that was approved earlier this year by the Executive Board of the World Health Organization, calling for action globally to improve oral health. And there's many groups around the world, not only academic institutions and industry partners, third-party payers, etc., but groups such as, for example, the Alliance for a Cavity-Free Future and others that are already working with individuals and organizations such as WHO to try to identify not only ways to monitor the disease process globally, but also measures and policies that can be cost effective. Ultimately, the need is really to shift from the current model of care for this disease process that is centered around cavity of disease management to health management in the form of caries prevention and early intervention. So in healthcare, improving prognosis is obviously the ultimate goal of preventive and therapeutic decision-making. And dentistry needs urgently accurate caries risk prediction models that, when implemented and results effectively communicated, can really impact behavior change, not only from our perspective, from the patients, but also from the providers and treatment decision-making, resulting hopefully in better cost-effective improvements in health outcomes and person-related quality metrics. Eventually, with the implementation of a more holistic approach to interoperability of data sources, as we were discussing in the general session, might permit a more sophisticated data mining and analytical methods, which will increase our ability to monitor patients' caries risk really in real time. Now, if you really think in dentistry and the area of caries risk assessment, where we are in development of caries risk tools, validation, and impact assessment, unfortunately, we're in the very beginnings of this pathway. Many of the risk tools that we have available in dentistry are expert-based risk tools with limited or no validation. And if there's any validation, many times it's very narrow on very selective population groups. And so we really don't have what we need to be where we need to be, which is really looking at a valid, accurate, and calibrated risk tool that we can then implement and look at changes in clinical behaviors and cost reductions and improvement in patient outcomes and facilitating clinical decision-making and using the best ecosystem or data available in existing ecosystems. Now, we have some examples in the literature of evidence-based, risk-based care that give us some hope. This is, for example, data from a study in Australia, implementing a very simple caries management system where risk assessment was based just on a stratification based on caries experience and selective use of some evidence-based approaches. And in this project, even after 7 years of completion of the initial trial, there was still about a 30% caries experience in the intervention risk-based group compared to the control practice, which was current care. Another thing to consider is that because access to care for dental procedures is a challenge for many population groups around the world, and because of many of the preventive interventions that we know are effective can be delivered in a variety of settings outside of a dental office, interprofessional care has been advocated as essential to improve oral health worldwide. I love this diagram from the DentaQuest Institute that it really encompasses interprofessional care into its component involving integrated care and coordinated care. And the element that I want to highlight out of this diagram is the need for risk stratification. And here's where I'm going to talk to you about this NIH project that we've had over the past 10 years in developing and initially validating some accurate risk assessment tools that can be provided in the medical and dental settings. They can be provided in digital platforms that don't require an in-person interaction, and looking at economic modeling of this targeted care. This is the funding that I have been discussing. We have been following a cohort of children since age 1. These children are now turning 9, and we have a variety of different data that have helped us develop and initially validate across a number of different populations groups this initial tool. Now, for those of you who are not from the US, you might not be aware that in the United States, recommendations for preventive pediatric health care, so in the medical setting, include oral health. So oral health is part of the anticipatory guidance that is provided in well child visits, in addition to having policies and reimbursement available to provide fluoride varnish in medical settings. But these recommendations are not risk-based. And the reason they're not risk-based in part is because of the lack of a validated risk prediction model to implement and assess a risk-based system. And because of that, the policy right now is that this should be applied to everyone. Now, a few years back, we were lucky to have, with some partners, a grant from the Centers for Medicaid and Medicare, looking at how we could improve implementation and delivery of preventive interventions for dental caries in medical settings, and looking at how we could increase the coordination of healthcare and healthcare data between medical and dental EHRs. And we learned many things out of this initial project. One of the things that we learned is that if you address some of the existing barriers, you can in fact increase the provision of these services in medical settings, both anticipatory guidance, oral health screens, and fluoride varnish applications. But we also learned from data from some of our other grants that the delivery of a lot of the services in medical settings appears to be, in many cases, still subjectively risk-based. So even though the policies and the reimbursements would be there to do it for everyone, many times when it's happening based on some subjective risk stratification, which suggests that if we were able to provide an accurate model, implementation might be facilitated. So risk models obviously need to discriminate between patients are higher and lower caries risk. But not only that, they should be able to provide an accurate estimation of the patient's absolute risk to allow clinicians to make informed decisions on how to prevent and improve outcomes. So absolute risk should be displayed in a user-friendly form and flow seamlessly in clinical environments to facilitate clinical decision-making. So as part of this project, we are now ready to publish our initial risk prediction tools for early childhood, looking at a variety of variables and initial validation and determining caries patterns and trajectories in relationship with caries risk variables. We're also modeling the economic impact of delivering well-known, available evidence-based risk interventions based on this risk stratification compared to current practice or prevention for all. And Dr. Lisa Prosser's group from the Child Health Evaluation and Research Center at the University of Michigan Medical School is in charge of this economic analysis. So what is the role of the learning health system? Well, I believe these systems, learning health systems are essential as we look at implementation of a risk stratified approach to caries management. They're not only essential as we look at how we implement clinical decision support systems and quality measures around improving health in a risk stratified version, but looking at the implementation of health policies and development and implementation of clinical guidelines. And Alonso, Dr. Carrasco-Labra is going to be talking much more about that in the second presentation. So where are we going? We really want to be at a stage where we're implementing a risk-based care management model and learning health systems that support collection of data routinely collected during care encounters can help with implementation and continuous improvement. So the responsiveness, the ability of the system to respond to that risk stratification in a way that monitors health outcomes and costs and decision-making. And we're looking for collaborators. So if you are interested in this area and have expertise in learning health systems, we would love to talk to you. So in conclusion, validated, accurate, and calibrated category risk prediction models are needed to implement risk-based care and to monitor the success of evidence-based care preventive interventions. And Alonso is going to talk a lot to you about the evidence ecosystem and the work that they have been doing at the American Dental Association. These models, driven by artificial intelligence or not, within a supportive culture of routine data collection to continuously improve health outcomes. And of course, a nurturing incentive structure that has to support these decisions should facilitate a shift in care management towards prevention and early intervention. In other words, a move from disease management to health management. And the goal ultimately is to improve health outcomes in a cost-effective manner. I thank you very much for your attention. And I am going to now allow Alonso to share his screen and continue with the second part of this presentation. And again, we will be addressing questions at the end of Alonso's presentations. Thank you very much.
I just would like to say that it's very brave from Dr. Fontana to make such a statement about how misguided we are at the moment with our risk approach to the disease. And I think it's important to hear that message and take remedies to solve that situation. So rather than randomly assign resources, we are intentional about it. Thank you for that great presentation, Dr. Fontana. My presentation today is about the learning health system and evidence-based clinical practice guidelines. I always have a sub-theme for my presentations, and in this case is the role of guidelines and the optimization of the knowledge base. You will see that my presentation is going towards a certain direction, specific message that I would like to bring, and we will be able to connect with what Dr. Fontana just presented for the last third of the presentation. Regarding conflict of interest, I have no financial conflict of interest to report for any of the content you see here. I have a number of intellectual conflict of interest that I will be happy to discuss later if needed. So 3 objectives for this session. The first one is to describe the role of evidence-based clinical practice guidelines in the future of healthcare, define what is needed to make the evidence ecosystem or the knowledge base, which is a concept that I hope I can introduce you to, a fully functional piece of this learning health system. And finally, define the role and utility of risk prediction modeling and the development of clinical practice guidelines, the influence in practice, and how that fits into the learning health system overall. So for this, I brought short slides that can hopefully make the point. As you can see at the very beginning, bottom left corner, it is a simplified model. I want to start saying that. The purpose of this is to be able to present this concept in a very short amount of time. Happy to discuss the complexities of them as questions come. So basically, on one hand, we used to have information in the shape of clinical practice guideline, algorithms, pathways of decision, information that is coming from the medical management of our patients, dental patients. We also have drug databases that explain how prescriptions should be happening, interactions across this prescription for different patients, decision models that are built at a higher level when resources need to be determined and prioritized. Overall, all the output from clinical research, the output from basic research, fundamental to support everything we do on a daily basis. And in the future, a new type of data that will be the data that we mine from the application of AI to large data sets and repositories like the one that Dr. Mariano was discussing with us at the beginning of this conference. All these, we hope, should be presented in a digital format, and this is what we call the knowledge base. I call it the rules of the game of being a clinician. These rules are overall scattered across different platforms, across different stakeholders. So dentists need to do a lot of effort to just to stay updated in all these different resources. Another very important disruptor of the health system is coming now, which is the collection of information from electronic health records. And what you see here is a list of different type of deliverables that we find and pieces of data that we find that are consistent with what happened in a day-to-day care of patients, including the big area of omics, extremely important these days. These two worlds, we hope, at some point will be able to interact through what we call an inference engine, just to find a way to call it. And this inference engine is supposed to connect these pieces of information together and help us to provide patient-specific recommendations, decision aids, and implement shared decision-making at the level that we hope can happen. Risk assessment can happen seamlessly and recommended depending on the patient features, diagnostic tools that may be required to rule in or rule out disease, alerts, with the hope that at the end of that process, we will certainly be able to measure outcomes in practice. And if we measure outcome in practice and we have our knowledge base organized, value-based dentistry can become a reality. So in this presentation, within what the knowledge base is about, I will focus on the role of clinical practice guidelines. First question for us to try to deal with today is there any role for clinical practice guidelines in the learning health system and the future of healthcare? And I can tell you that the way we define how patients are treated and a level of the profession is really by consensus. And there's nothing wrong about consensus. In fact, science is probably the best example as what can happen when humans organize in a stochastic way to decide what we believe in, what are the conclusions of our observations, and how can we move forward based on those observations. So there's nothing wrong about consensus. However, consensus is always used or often used as an opposite of what is evidence-based. And this is an interesting article published in the Journal of the American Medical Association last year that actually brings to our attention the issue that evidence-based and consensus-based guidelines are concepts that are misguided and misleading, because any clinical decision, any policy decision, any clinical practice guideline decision is based on consensus. Consensus is everywhere and is the only way that we can apply science to practice. The issue is that when we try to reach this consensus, in some cases, some people bring evidence, other people do not bring evidence. And it's important for us to understand that all guidelines, all policies, even those that are evidence-based, are also based on consensus, the consensus that need to be reached, because the data doesn't make the decision on its own. And the role that guidelines play as these places where consensus occur is very important. What you see here is a policy brief from WHO in the European branch, published last year, where they present how to build the framework for value-based care in a way that we can change the perspective on the health system moving forward. And what you see in this figure here is examples of policy levers to enhance health system value. I marked for you in red, specifically for health improvement section, every single time that guidelines are interacting with different stakeholders, national policymakers, provider organizations, practitioners, citizens, and patients. So guidelines are here to stay, and they need to be done in an efficient manner, in a way that they can quickly update it, and rapid change can occur. If you look at other models for value-based care, this one is from the LHS, published in 2019. They also talk about similar concepts, building capacity and capability to translate and implement the best available research evidence into effective action to increase value. And finally, I would like to show here an article that Dr. Mariano is actually a co-author in this manuscript, published a few days ago in The Lancet, when they talk about WHO SMART guidelines and the optimization of the use of guidelines at different countries using digital means. Very interesting elements of this, the presentation of the knowledge base at the top. You can see here that is a very important aspect of it. The delivery of digital tools to implement those recommendations, and what I call here this virtuous loop between the tools that are delivered, implementation of these tools in practice, and how those go back to the research and the body of evidence to become a new piece of information. The second point that I would like to discuss today is what is the importance of knowledge base and how we can optimize it within the learning health system. So the knowledge base is basically everything that makes clinical practice a reliable practice based on science, hopefully obtaining the best outcomes possible for our patients. And when we're building this consensus, again, it's important to have the full perspective when we're focusing on a specific healthcare problem. And the way that at the moment, the most valid way at the moment to build that map that allows us to see the entire picture is the production of reliable, trustworthy summaries of the best available evidence in the shape of systematic reviews. And you will see that throughout pretty much all documents that highlight how guidelines should be informed, pretty much all of them said that conducting a systematic review of the available literature to support the recommendations from the guideline is essential. Even if one accepts that premise, the challenge doesn't stop there. This is a slide that summarizes a very important initiative from a group called Epistemonicos. Epistemonicos is at the moment the largest repository in the world for systematic reviews and meta-analysis. As you can see here, they identified back then when this publication was released, more than 300,000 systematic reviews, and they were able to identify almost 2/3 of those by the use of automated methods, AI, and other means. So even if you want to use systematic reviews for making decisions, for reviewing guidelines, for informing policy, they are everywhere, and we need to be able to manage them. Of course, there's a lot of waste in that. There is a lot of duplication of reviews. If you look for silver diamond fluoride in a time frame of 3 years, you can identify more than 15 different systematic reviews answering pretty much the same question. Always the question is, do we really need 15 reviews answering the same question? Another challenge that people building guidelines and trying to operate using evidence is that the methodologies are getting more and more sophisticated as we learn about the decisions that are made, how these documents inform practice, what are the implications for practice. We go back again, review our process, and our process gets more and more complex with the establishment of different standards. So we need to organize this in a way that we reduce waste and we optimize the way we work, avoiding silos. What you see here is a framework, it's a proposal for what we call the Global Evidence Ecosystem for Oral Health, an initiative that started a few years ago with the collaboration of a number of relevant stakeholders from different countries. And what we're trying to do here basically is to make sense of all the systematic reviews, guidelines, decision aids, implementation tools, and share data across platforms. So if you go to the bottom left corner, you will see that the first very important piece, essential piece, is the production of evidence. Evidence of high quality from primary research, from basic science, evidence that can be brought together from the use of means of real world evidence approach, and also big data. That's coming, right? These data should be summarized and at some point presented in systematic reviews, meta-analysis, and other evidence synthesis related deliverables that can be used by policymakers, by decision makers, by patients to decide what is the best course of action. Here is when many organizations around the world, and I'm presenting to you some of them here, need to interact, talk to those summarizing data and those using that data for decision making in a way that we can really get answers for the important questions, in a way that organizations like the one that you see on the top right corner can save resources, avoiding conducting additional unnecessary systematic reviews, but rather optimizing the ways these are conducted in a way that they all interact in this network. Of course, for this data sharing across this ecosystem, there are a number of values that need to be presented. A culture of sharing and innovation, common methodological standards, so we trust each other with our data, coordination and support, trustworthy evidence that we present, the use of digital tools and platforms, and finally, a digitally structured data that can be machine readable and can be transferred across settings. Only then we will be able to produce high quality deliverables that are easy to update, to implement, and to revise. The final point that I would like to discuss with you is what is the role and utility of risk prediction models in the development of guidelines. And for this, I have an example that maybe some of you have seen before. I will present to you a very short story about how guideline panels use risk stratification to formulate recommendations. And this panel will be using a Cochrane review on the use of fluoride varnish for preventing caries in children and adolescents. As you see here in the box in red, they report that the use of fluoride varnish in children and adolescents, you can expect on average a 43% reduction in DMFS within this population, a reduction in the incidence of caries. So that's broadly a relative risk of 0.57 because it's a 43% reduction. So how panels use this information? Well, let me introduce you to a patient. And through the patient, we probably can extrapolate to how panels use this data. What you see here is a patient. His name is Justin. Justin is 14 years old, barely brushes his teeth. He's under orthodontic treatment at the moment, drinks 3 energy drinks per day, had many restorations. A first molar was extracted. And if I asked you, what is the probability for Justin to show a new caries lesion in the next year? Most of the time, the audience said high probability for that. Let's fit that probability for now at 50%. The other patient is Megan. Megan is 26 years old. She brushes her teeth 3 or more times a day. They're perfectly aligned, not ortho treatment, only drinks tea, no sugar, no restoration, no extractions. Same question, what is the chance for Megan to get a new caries lesion in the next year? Fairly low. For the purpose of the exercise, I would determine arbitrarily that as a 2% risk. Ideally, these estimates that you see at the bottom should be provided from a risk prediction model that appropriately determine, as Margarita said, the baseline risk for that particular patient. So when we have these two estimates from our prediction model, we can theoretically apply for a varnish to these two patients. As I described before, the systematic review suggests a 40% reduction in relative terms on the incidence of caries. So when we theoretically apply for a varnish to Justin, we experience a 30% reduction. And when we apply that to Megan, we move her risk from 2% to 1.2%, which means in absolute terms that Justin now has a 20% reduction or 20% chance to present a new caries lesion, while Megan has a 0.8% chance of presenting a new caries lesion post fluoride varnish treatment. Panels do not necessarily look at Justin and Megan, but rather what is high risk or a very low risk population. And a panel in formulating a policy or a guideline may appropriately formulate a recommendation for the use of fluoride varnish in the population at high risk, given the large reduction that they can experience. However, in the case of someone like Megan, maybe the cost and effort would not worth the effort of applying it. This is the health system we're all familiar with. Guidelines often operates at the top of that, and risk prediction model operates at this level here. When the knowledge to performance component, basically prediction model can help guideline panels, as I presented before, to implement risk-based approaches to recommendations. Margarita mentioned to us that panels have failed in many cases to provide risk-based recommendations, given that we do not have the tools in practice to reflect such a risk. And the second component, the one that also Margarita mentioned, is risk prediction model can help patients and clinicians to monitor the impact of risk mitigating interventions. If you want to see more about the content of this presentation in a little bit more like a formal format with more time, this is an article we published in JDR with Margarita and her team and other colleagues. So take a look. Here is another slide that we include as an appendix in that material that basically present the same concept. And this one, if you want to learn more about how to appropriately evaluate prediction models, if you want to get the tools to discriminate which ones are high quality from those who are not very high quality, I recommend you this article published in the Journal of American Medical Association in 2017. In summary, guidelines are and will be an essential piece of the learning health system. We need a digitally structured living knowledge base. Then the global evidence ecosystem for oral health is serving as a laboratory to test data flow, data sharing, stakeholder engagement, and reduce waste in research and policy. Risk prediction modeling applied to guideline development helps to improve risk-based recommendations for practice. And risk prediction models also help patients and clinicians to monitor the impact of risk mitigating interventions. Thank you.
Thank you very much, Alonso, for joining me in this session. And we're now open for questions. Please make sure that you write your questions in the chat box, and to either Alonso, myself, or both of us, and we would be very happy to try to answer them. Well, while people start to think about some questions, Alonso, is certain that you, the group that you have described, as well as the work that I have described, there's a lot, we have a lot of work ahead of us to make this goals a reality, and working with others around the world as well, right?
Yeah, I agree that there has to be a conversation at a larger level. That conversation may require open discussion about the contribution that all these stakeholders need to make, how their contribution will be acknowledged, how basically that contribution can contribute to people's careers. Sometimes we're very jealous about our own data because our data allow us to publish, and we need to move forward in our careers. There are a number of aspects in relation to the sharing of the data that definitely represent a challenge moving forward.
Great. So we're starting to get some questions come through. Kathy, do you want us to manage it, or do you want to try to manage some of these questions? How would you prefer? So I'll just go down the line as I am seeing them coming in. So there was a question about the ethics of applying risk-based models to clinical decision making. And I think that is a really good one because I think there's, it could be the misunderstanding that we might be having some segments of the population that are not benefiting from some of this evidence-based strategies. And I don't think that's necessarily what we're saying. There might be some strategies that are, from a public health perspective, things that we want to advocate for the entire population to maintain a lower population risk. And then there might be a combination of strategies that, because of cost and effectiveness, we really want to target particularly to those that would benefit the most from those interventions. Alonso, do you want to add anything to that?
Yeah, I would like to add from the ethics perspective, just to provide problems and not solutions, as most of my presentation did. Only problems and questions. One of the issues is the principle of determinism. When when we try to improve our risk prediction models, and we go now into the field of genetics, and we see that we can learn a lot from that information, how that principle that genes will be connected to specific phenotypes will influence the way that decisions are made, and may maybe affect patients with aspects in relation to stigmatization or restriction to access for certain job or so it's a very interesting concept. I think we're not there yet, simply because we're not being able to build reliable prediction models yet. When those models are built and we're incorporating data that is coming from a more diverse type of source, we will be facing a number of ethical challenges. So just one to bring to the table is the principle of determinism, and how genes may affect that, how that affects the individual itself. And now it knows that I will be affected by a certain condition irreversibly.
Right. Thank you, Alonso. The next question is about how can the prediction models be integrated in digital health options and then utilized on larger scales? And I think this is an excellent question because the reality is that we are moving, as you saw in the keynote presentation, and for the need for digital health systems, right? And interoperability of data between medical and dental healthcare systems, for example, or electronic health records, and then at a higher level. So I think it is for a risk-based strategy to work, it is essential that whatever that risk model is and however that risk model is displayed, it be easy, be integrated within the healthcare system, hopefully be accessible to both patients and providers in an understandable manner, and in a way that might not necessarily require an in-person encounter to be able to have the collect data and to have the discussions about what those risk factors may mean as part of the healthcare delivery system. Unfortunately, for at least Carrie's risk, we are far away from that goal in part, and I think there's a question later on, how about randomized clinical trials testing this risk-based model? The problem to test a risk-based model is that you must have an accurate, validated, and calibrated risk assessment tool that you can use as the base for the decision-making process. If not, everything else kind of falls apart a little bit. Now, of course, you can learn from a learning health system about accuracy of predictors, and you can look at different levels of incorporating artificial intelligence into the prediction modeling itself and the testing of the prediction model itself. But ultimately, we're very far away, I think, from where we want to be. We're in the initial stages. But if we don't have these conversations right now, and if we don't think about what are the elements that we need to consider, we're never going to be able to get there. So Alonso, I don't know, this is a broad question about digital integration and randomized clinical trials to test some of these models, et cetera. But if you want to add anything, I would certainly welcome.
Yeah, I have nothing to add. That was a great response. Anything I would say, no, that's a great response.
Well, then the next one I'm going to throw at you, and this is from our colleague and friend, Dr. Heiko Spalek, who we have been having the pleasure to collaborate with on many of the ideas that you heard today. So Heiko adds, do you think that use of data and evidence can help shape a suitable workforce for our communities, like mid-level providers and fewer specialists?
That's very interesting. It could, and probably will depend as to how these tools are developed and which type of conditions are we targeting with these tools. Certainly, when we are investing on producing these sophisticated methods, hopefully we will go for those big wins for diseases that are more prevalent, for diseases that we can see on a day-to-day basis, or has a high cost moving forward. I would have thought that dental caries is one of those, and I hope that will be one of those. If you go from that perspective, then that opens the door for having these type of tools implemented in settings like the ones that you mentioned in this question, Heiko, where now we empower what can be done in those settings and show more value for what happened in those settings based on our ability to measure risk with a responsive tool that would show that risk has been reduced, and therefore even estimate saving cost, which is also something that is in absolute need, at least in probably most countries, particularly in the United States. So I definitely think that tools like this can empower the mid-level section of healthcare in dentistry as well, to make better decisions, to show value to the entire system through the means of measuring change in outcomes that are relevant for patients and for the system overall. So very interesting question. It will depend really, if we focus on diseases that are actually managed by specialists and ignore the other ones, maybe these will go in that direction. Very interesting question.
Thank you, Alonso. And I think, Heiko responds, thanks, Alonso. Agreed, we need to reduce costs to improve access. Yes, we're all in this together. There's one more question, and I'm just going to read it out. And Alonso, either you or myself, we can take a stab at it. I think both of us certainly could apply. So it says, prevention was included as an aspect of caries risk prediction, with the typical dental approach being treatment forward, so reactionary, and financial incentives tied to invasive treatments, which I think is the case in most places around the world, right? Do you see these models leading to a greater adoption of preventive treatment? How so? Do you want to start or do you want me to start? I think both of us can jump at this question.
Please go ahead. You can go first. You can go
well,
first.
I will be very brief. I will just say that the idea of having a risk-based care approach is really finding a better way of using the evidence that we have to manage this disease process in a less costly and more effective manner. And we know that that happens when we use strategies that are targeted towards prevention and early intervention. We already have a model that is based on managing the consequences of the disease, and we know how unsuccessful it has been to really control this disease process, considering that this is indeed a preventable disease. So something has to change. And we need to test whether a risk-based approach will be effective. We have some small indications in the literature, but in absence of really well-developed risk assessment tools, this is still a hypothesis to be tested into models. And we do need to do research in this area. But to me, a risk-based approach really depends on the implementation of evidence that is effective for prevention and early intervention. If the only thing that we're doing with the risk-based approach is just identifying some behaviors and then just treating the disease with the current reactionary, as the question asked, approach, we're not going to change anything. We're not going to be able to reduce cost and really improve health. So Alonso, I know you have a lot to add because a lot of the evidence domains fall within your purview.
So one thing that I can say, if I'm allowed to share my screen again, is that this model that I show here is a model that can work. This is my opinion, I can say, but we can reach here to value-based care, which means we pay for providing good care that is verifiable to the measure of outcomes in practice, can only happen when these two talk to each other. You cannot expect that we're going to be able to measure all this and present to clinicians and other healthcare providers the idea that we're going to monitor what they do now, and we're going to measure your performance, and I'm going to compare you with the national average or the clinics near your clinic and provide you with estimates without having the knowledge base organized, optimized for easy access with clear and optimized recommendations. Because why would I share my data with you? Why would I like to be audited? And the only way to go there is breaking that wall of being audited, but now help me to get there. When I explain this concept, I often use the analogy of the electricity bill. So on one side of the electricity bill, you have all your estimates, let's say for whatever condition you treat or you manage in your practice, this is how you're doing. And this is how you're doing compared to the national average, to clinics similar to yours, adjusted by the severity of the disease, of course. And then on the flip side, if you're not doing very well, we will tell you how can you improve. Similarly, where the electricity say I personally always spend more electricity than my neighbors. I don't understand why. But then when I flip my bill, the bill said all the measures that I can take to reduce that estimate. And next month, we're going to let you know if you did a good job. Similar to that, you can only go and audit and ask for outcomes and expect that clinicians will have a positive attitude towards being audited when you're ready to give them the solution to the potential problems you will find. Otherwise, this is just about making me look bad as a clinician. Only then we're going to be able to have value-based care.
Thank you, Alonso. You're not alone. My electricity bill is also higher than all my neighbors. I think this last question is really for you, Alonso. It talks, and I'm going to read it out. So excellent presentation. Thanks a lot. Is direct input of primary research data, for example, from clinical trials, already being made into the global health ecosystem? Or for now, do you plan to work only with what was published? And if not, are you re-entering data directly into the model? How do you see this in the future?
So at the moment, the current systems are basically very strict about the type of study design, and we know from the perspective of policymakers that is absolute. Our perspective of exclusively focusing on randomized controlled trials when answering questions of any sort is problematic, and that is one of the things that even Cochrane have acknowledged by now developing methods when they include other type of study design, not only randomized controlled trials. So that's the first part. The first part is that we need to also break that paradigm. The best studies for building care prediction models, for example, are these large cohort studies that are conducted throughout a number of years, like the one that Margarita showed us. Basically, Margarita is conducting our own Framingham study for dentistry. And those studies are, the study we need for that is a cohort study. So data needs to be richer if we really want to use and enhance the knowledge base to inform practice, to inform policy, needs to be properly organized. The second thing is that data that is coming from practice directly, how that data is processed by decision makers. That's a question that nobody have answered. For example, how a guideline panel use data that is mined from a large healthcare provider system when a recommendation is implemented. We have no idea. Basically, we look at trials, we look at those estimates, this is good, we go and do the recommendations. Nobody had monitored whether those recommendations are actually providing the benefit that they're supposed to provide based on the data from the trials. That connection should happen, and that data, as Carolina is suggesting here, needs to be brought back into the ecosystem in a shape or form that at the moment has not been defined. We don't know how that can happen. So guideline panels end providing these recommendations and wishing for the best.
Thank you, Alonso. I think we have a couple of minutes to, if there's one last question. And if not, I really want to thank Alonso for joining me in today's session. I want to thank all of you for attending today's session, and of course the fantastic keynote speaker and keynote session that we had. I hope that you learned a lot, and I hope that you will join us in this efforts to improve care for all of our patients and the populations that we're so privileged to serve. So thank you very much. Have a wonderful afternoon, and we look forward to please make sure that you complete the feedback for this meeting, and you will get it, like I said, a link to the recording and to the slides at some point after this presentation. Thank you very much, everyone. Have a wonderful afternoon. Thank you, Alonso.
Margarita, for your invitation. Bye-bye.
Bye-bye.
Great job, you guys.
Thank you.
Fantastic. Thank you so much.